Dear colleagues, this is a new case and a new tumor. Today we are going to talk about the small round cell tumor. It's a 25 years old female with a 6 months history of the left knee pain and a progressive swelling in the popliteal fossa. The patient had a flexum of the knee, and we have observed a melon-shaped fixed mass in the posterior aspect of the thigh. X-ray of the knee were unremarkable unless an opacity of the soft tissues posteriorly. The MRI showed a huge mass in the soft tissues passed on the posterior cortex of the distal femur with a limited involvement of the medullary canal. This mass is heterogeneous with high uptake of gadolinium. Femoral vessels were involved in the tumor. The angio-CT confirmed that the vessels were trapped within the tumor. According to this image, this is either a soft tissue tumor invading secondarily the bone, or a bone tumor with a large extension to soft tissues. Each time we have a limited extension in the bone contrasting with a large soft tissue mass, Ewing sarcoma should be considered, and we will explain why. Biopsy revealed a proliferation of monomorphous round cells with a high mitotic rate associated to a large necrotic area. We are facing a malignant tumor. 2 points need to be mentioned here. First of all, this high rate of mitosis can explain how can this tumor reach a huge mass even before then an osteolysis can be observed on X-rays. Secondly, tumors are recognized according to what tumor cells produce. Osteosarcoma is recognized by the osteoid. Chondrosarcoma is recognized by the chondroid matrix. In this case, the tumor cells don't produce anything, so we can't determine the differentiation of the cells on morphological features only. Indeed, a lot of tumors present a proliferation of small round cells, and we can cite the Ewing sarcoma, rhabdomyosarcoma, synovial sarcoma, lymphoma, and so on. Even though these cell tumors are morphologically the same, the genome of each tumor encodes for specific proteins. To identify these proteins, we use specific antibodies, and when they bind the corresponding antigen, they stain the tumor cells. This immunoreaction is the base of immunohistochemistry. In our case, the tumor cells showed an intense membrane staining with CD99, which is characteristic of Ewing sarcoma. The diagnosis of Ewing sarcoma is based on the evaluation of clinical, radiological, and pathological features. However, to validate the diagnosis, molecular biology is necessary. Indeed, Ewing sarcoma is characterized genetically by a specific translocation between the chromosome 11 and 22. This rearrangement leads to a fusion of 2 genes, the FLY1 and the EWS, resulting in a chimeric proto-oncogene, which is responsible for cell proliferation, invasion, inhibition of apoptosis, and so on. Ewing sarcoma is the perfect proof that cancer is a genetic disease. The fluorescence in situ hybridization or FISH technique is used to detect this chromosomal rearrangement. We use a probe with 2 different signals. When the signals are fused, that means that it's a normal cell. However, in tumor cells, we have a split signal, which is specific for the chromosomal rearrangement. Inking staging system is commonly used in bone sarcoma. The AGCC has also proposed a staging system adapted to bone sarcoma, which is based on the size of the tumor rather than the site. According to both systems, the tumor is staged 2B. The treatment of Ewing sarcoma is well codified, and in all cases neoadjuvant chemotherapy is required. Post-chemo MRI showed a partial reduction of the tumor mass. Given the high sensitivity of Ewing sarcoma to radiation therapy, the patient received 55 grays, resulting in an excellent reduction of the tumor mass. Here we can appreciate the excellent response of the tumor to the treatment. We moved from stage 2B to stage 2A, and that's exactly what we expect from neoadjuvant therapy. This is very important since limb-sparing surgery becomes feasible. Don't worry, we are still talking about Ewing sarcoma. This is a tumor with a good response to chemotherapy. This is the pre-chemo margin, and this is the post-chemo margin. The question here is which margin should be considered for the resection, and there is no evidence that in this area there is no viable tumor cells. For that reason, it's recommended to irradiate the pre-treatment volume in order to improve local control. Radiation is performed post-operatively. In our case, it was performed pre-operatively given the insufficient response to chemotherapy. Actually, pre-chemo margins are considered when dealing with the bone. However, for soft tissues, we have to consider the post-chemo volume. We used a megaprothesis for reconstruction. Two tricks should be mentioned. It is recommended to use a rotatory hinge to decrease the constraints on the prothesis, and hydroxyapatite ring to improve bone ingrowth. Histology confirmed the excellent response to the cell tumors to the neoadjuvant multimodal therapy with no viable cells left. To conclude, I would like to say in one word that the management of bone tumors is teamwork and should be done in a referral center. Thank you very much for your attention, and looking forward to hearing from you. Bye-bye.